Good afternoon. My name is Jaap van Laar. I would like to warmly welcome you all to the June's edition of Forum Live, where we'll be discussing difficult to treat rheumatoid arthritis. Please introduce yourself, Georgi and Elena.
Thank you so much. Welcome, everyone. It's really my pleasure to be here. My name is György Nagy. I'm a rheumatologist from Semmelweis University, Budapest. Thank you.
And a warm welcome also from me. Thank you, Jaap, for the introduction. My name is Elena Nikiforu. I'm a rheumatology consultant at King's College Hospital here in London, and also an adjunct senior lecturer at King's College London.
Okay, so these are our disclosures. Just a few housekeeping rules before we kick off. Please remember to submit your questions via the Q&A button on the Zoom toolbar, and please do not use the chat, as we are not able to see the questions on the chat box. So in terms of the agenda, we have a few topics which we hope are of interest for you. I will start with presenting a clinical case just to set the scene, and then we'll have some time for a Q&A, and then Georgi will take over with the finding difficult to treat rheumatoid arthritis. Again, a few minutes for Q&A, and then Elena will give the last presentation. And then we have hopefully a bit more time for a Q&A for a panel discussion. So let's start with the topic of the clinical case. This is a real life case that of a lady I've seen in the outpatient clinic some time ago. She was 60 years old when I saw her for a second opinion. She was overweight, a past smoker. She ran her own company, and she was divorced and a mother of 3 teenagers, so not an easy situation. Her medical history, she had a diagnosis of rheumatoid arthritis for a long time, and she had been treated with many conventional drugs and very many biological drugs. And 11 years ago, she had been diagnosed with deep vein thrombosis. And 10 years ago, she had undergone an orthopedic surgery because of a torn meniscus. And she had a replacement of her right knee some time later. And about 2 years ago, she was diagnosed with ischemic heart disease. So her current symptoms consisted of mainly fatigue, morning stiffness of about 2 hours, and painful joints, multiple joints. Interestingly, she was treated with monotherapy with prednisolone, and she had gotten used to kind of self-medicate. So she had been using varying doses from 7.5 to 50 milligrams, dependent on the symptoms that she had. She was also taking painkillers, celecoxib, but despite these drugs, she was still symptomatic. Her BMI was 32. At physical examination, she had signs of skin atrophy with hematomas. And at rheumatological investigation, she had clearly synovitis in multiple drugs. She also had 12 tender joints and a VAS of 60 out of 100. The laboratory findings are given on the right. And as you can see in red, she was rheumatoid factor strongly positive, CCP positive. She had an elevated set rate, so clearly pointing to systemic inflammation. And taken together, these results pointed to a DAS28 of 4.95. These were her X-rays. She didn't have any erosions, interestingly. Her hands were, well, having some abnormalities consistent with osteoarthritis, as did the X-ray of her knee. As you can see on the medial compartments, there was a lessening of the cartilage. So clearly also pointing out that she had underlying osteoarthritis. So on the right, we have a score, a timeline of the DAS28 over time, starting in 2000. And as you can see from this, she did have an initial drop in DAS28 with the initial medication. But after about 2003, her DAS28 continued to fluctuate, but never really did she have any DAS28 compatible with a low disease activity, let alone remission. So clearly, this was a lady with a persistently elevated DAS28. And how does this compare with her medication history? Because as I told you, she had tried multiple conventional DMARDs and biologicals. And when going back through the notes, we did find and confirm that the treating rheumatologist had tried to treat her according to the EULAR guidelines, which, by the way, are heavily focused on medication, as you probably know. So, yeah, what do you do with a patient where phase 1, 2, and 3 have been basically completed, but the patient is still having active disease? And that, I think, is the question for today's webinar. So we did some studies in Utrecht recently, and these have been published. You can read the original publications. First of all, we wanted to know the healthcare utilization of patients with difficult to treat rheumatoid arthritis. And we found that the costs of managing these patients is about twice the cost of a patient who does not meet the criteria for difficult to treat rheumatoid arthritis. And by the way, Georgi will expand on these criteria and definition in a minute. So this is really noteworthy and of relevance for society. These patients cost a lot of money. And if you look at the individual components that compose these costs, it's not just drug costs that are higher, but also components like other resources. And with this, we mean, for example, the time that family members need to invest in managing the disease of the patient. So clearly, difficult to treat rheumatoid arthritis is not just a problem for an individual patient. It really affects the whole family and also leads to income loss, as in our patient. Our patient, by the way, struggled to keep her company alive because she had symptoms and had to be on sick leave quite a number of times. We also looked into different subsets of difficult to treat rheumatoid arthritis, and using some sort of principal component analysis, we were able to identify 3 subgroups of difficult to treat rheumatoid arthritis. First, patients who were non-adherent and dissatisfied. The second subgroup, patients with pain syndromes and obesity. And the third group, patients with what we would call true refractory rheumatoid arthritis. And if you look at the barriers to treatment adherence, because treatment adherence is essential in this subset of patients, it appears that mainly adverse events determine the issues that patients have with treatment adherence. So if you look at all sorts of possible contributing factors, we found in this analysis that patients were mainly non-adherent or becoming non-adherent after having experienced adverse events in the past. Whereas if you look at the positive side, facilitators of optimal treatment adherence, the most important contributing factor was the positive relationship with the treating rheumatologist. And of course, we all know as doctors that a positive and good relationship with the patient is essential in maintaining treatment adherence. So this is done this is depicted in a slightly different way. kind of heat map where you can see the three subgroups differing in red and green fields. But basically, this is summarizing the previous two slides. So how would you need to deal with these patients? Well, I think it's first critical to think about possible factors that lead to difficult to treat rheumatoid arthritis. These could be disease pathology related. As you probably know, there are different types of synovitis, one of them being immune, and these patients in particular seem to respond poorly to immunosuppressive medication. But there are also other factors. Smoking is, of course, well-known. Inappropriate medication use, we can discuss non-adherence, adverse drug events. So it's critical to really analyze these contributing factors before you make treatment decisions. And I think that ends the presentation of the case. So if you have questions for me on this topic, please submit your questions via the Q&A box. And otherwise, I'm sure that Georgi and Elena have some questions. So let me see. Okay, Elena, Georgi, you have any questions that we can use to start the discussion?
Thank you. Yeah, I mean, that is such a, I think, real life case. We come across many similar cases also here in London, and the complexity of it all is striking. And as you said, I think you made a very important point. It's not just the burden on the individual, it's more the wider burden, the societal burden. I was just interested, have there been any studies thinking about the wider perspective? I know you presented Nadia's cost of illness study. Have there been any other studies looking into this, and perhaps the work disability element, because that's an important aspect as well, like the burden on the work function.
Yes. So I think the critical problem with these patients is that many of these costs are not visible to society. And that, I think, is a critical problem that's probably also underestimated by health insurers, by healthcare insurers who have to pay for the costs. So many of these costs are kind of hidden, like, work employment will be paid by maybe a Ministry of Social Affairs, whereas drugs will be paid by another ministry. So kind of the combination of these costs is rarely visible, but it's, I think, underestimated. So that's why I think, calculating the true costs of difficult to treat rheumatoid arthritis and seeing that these are double the amount of a normal patient is really striking.
Yeah, I agree. And just maybe to add an additional thought to that, I think it's important to keep in mind that it's not just the disease itself, which may be challenging and difficult to treat, but linking it a little bit to what we will hear later, the comorbidity element as well. We have patients who might be disabled because of a respiratory condition to undertake their work. So it's a very complex issue.
Yeah. So there are two questions from the audience. One from Ursula Mangold. How important is, in this case, the change of lifestyle? Is this an aspect you are putting a focus on? Yes, the answer is yes. But as we all know, we all realize how difficult it is to persuade a patient to quit smoking if they're smoking, or to lose weight is another a difficult task for many patients. So yes, we do in our clinic pay attention to it. But just to give an example, measures or programs to help patients quit smoking are not available in our hospital anymore. So this has all been referred back to the GP. And of course, GPs only take action if there is a problem. So, these are, I think the importance of lifestyle is recognized more and more, especially with this corona pandemic, where we know that patients with obesity have a higher risk of dying from COVID. So I think the importance of lifestyle is seen by many now, but changing lifestyle remains, I think, a challenge. The next question comes from Rodrigo Garcia Salinas. What's the role of socioeconomical condition in difficult to treat rheumatoid arthritis, for example, in a country like Argentina? Well, that's a difficult one because I'm not familiar with the situation in Argentina, but I'm sure that this problem is worldwide. I can't imagine that this problem is just one affecting patients in the UK, Hungary, or the Netherlands, or North America. This is a worldwide problem. And, so yes, we have to, I think that the critical message of today is that we have to be mindful of these factors. Okay, here's another one from Takahiro Suzuki. Are methotrexate intolerant and renal dysfunction patients predisposed to difficult to treat rheumatoid arthritis? That's a very good question. I think, Elena, you are going to tackle this one, right? Do you want to answer it now, or do you want to discuss it in your talk?
I mean, we can touch on it a bit later on. I will not cover specifically this, but I guess the answer is yes, because they have two, key issues there: methotrexate, drug intolerance, and the renal dysfunction. I think that they will be potentially. The simple answer is that they will be at risk of this. Yes.
Yeah. So we will come back to this question. It's a very relevant question.
May I just have a very short question as well regarding the issue? I think that one is a very important aspect, the cost aspect, and you very nicely clarified that probably difficult to treat rheumatoid arthritis is more expensive. Now, how do you see that? Would there be a way then, in the future, in case of some patients, even decrease the price of the expenses of the rheumatoid arthritis by optimizing the treatment or changing the diagnosis or whatever in the future? So just only talking about financial point of view, or what would you expect if we go through an optimal, like a clinical roadmap? Would it further increase the expenses, or maybe have a chance to decrease them in the future?
Yeah, well, the costs of biologicals are dropping, right? I mean, they have significantly dropped. But the downside is that more patients are put on biologicals. So although we are saving costs for individual patients, we are not saving costs for society because we are using more biologicals and targeted synthetic drugs. But you could think that, you could reason that if you treat patients with risk factors for difficult to treat rheumatoid arthritis, and we may address this at the end of our webinar, if you identify these patients early on and give them a kind of comprehensive treatment, including the best available drugs, then maybe you can also suppress disease activity in these patients and lower the burden of disease, which will finally, in the end, lead to cost savings. So I think that this window of opportunity, whether it's 3 months or 3 years, but if you miss it, you run the risk of having a patient who is going to cycle on multiple drugs, and it's not cheap. Can I just, there's one question left in the Q&A box, which is an important one, from Edgar Stemler, referring to the biopsychosocial model of chronic disease. And this is absolutely right. I think this summarizes maybe in one word what we are trying to convey today. The difficult to treat rheumatoid arthritis is not necessarily due to abnormal pathology of the synovitis. There are complex factors involved, as Elena pointed out, and she will elaborate on that more. And in the patients of my outpatient clinic, one of the key problems that we noticed with her is accepting the disease. This lady was actually not, in every discussion we had with her, she was not kind of willing or ready to accept that she had a chronic disease. So, if a patient is not really understanding the problem, even though she has good education and is a smart lady, but if the kind of internal barriers to treatment or management, that I think is also a predisposing factor for difficult to treat rheumatoid arthritis. So I think it just requires a lot of time investment from our side to have a proper discussion with these patients. I think we have tackled all the questions in the Q&A box and are ready to move on to the next speaker. Georgi, you'll take over and give us an explanation of how this project of difficult to treat rheumatoid arthritis arose, and also give people some concrete tools to identify these patients.
Thank you so much. I just had some internet problems, and I hope that it's back now and it will be okay. I just would like to add that probably if we can really describe an optimal clinical roadmap what to do with these patients, we can even decrease the cost of treatment in medium or long term by optimizing the prices and improving the life of the patients. And just one sentence about another recent question regarding intolerance. Any intolerance to any preferred treatments may, I think, increase the likelihood of difficult to treat anyway, especially methotrexate, because then you have less chance to pick the optimal medication. But anyway, so I would like to jump into my presentation. So pleasure to be here, and I would like to define difficult to treat rheumatoid arthritis. So basically, in the clinical practice, we all use the EULAR recommendations and obviously ACR guidelines as well. And currently, these recommendations suggest that treatment should be aimed at reaching target of sustained remission or at least low disease activity. And it works in most cases, as we see in the clinic, but still about 20–30% of patients are refractory. Maybe less, maybe more. I think it depends on the patient population, what we are dealing with. And that's why we thought a couple of years ago with Professor Van Laar together that it would make sense to work on this problem a little bit. And so we tried to think together, and we thought that we could form a task force. And with this task force, we could propose a terminology for these patients. How can we call these patients? And then we can propose a definition for these patients of refractory patients, and also to create a guidance for the comprehensive management of these patients. And that in the initial plan, initially as we planned, would include identifying the contributing underlying factors and adjust pharmacological treatment options. And the very important part, as we planned originally, to consider non-pharmacological treatment options as well. And initially, we planned to create a guidance which is complementary to the current EULAR and ACR recommendations and the guideline for the management of rheumatoid arthritis. So first, we tried to optimize the terminology, and there were several alternative options in addition to difficult to treat. For example, multi-drug resistant rheumatoid arthritis, or complex rheumatoid arthritis, or refractory or therapy resistant rheumatoid arthritis. And so it was discussed which seems to be the best option, and the task force really agreed, every task force member agreed that difficult to treat is the best terminology because it best reflects the real clinical problem in all cases, and all the other terminologies just pick a part of the problem. And difficult to treat is not completely new in medicine. It is already used in several other specialties, such in pulmonology as difficult to treat asthma, or cardiology, difficult to treat hypertension, or infectology as in different kind of difficult to treat infections. And if we just do a PubMed search for difficult to treat as a terminology in the title of presentations, and there are a large number of hits for that, and it's clearly increasing. Several hundred publications in the last 15 years is clearly increasing in the last years, and this year we already have several publications regarding difficult to treat rheumatoid arthritis. So what are the elements of difficult to treat disease? Initially, the task force agreed that there should be some elements of the definition. And so one element, as we originally planned, is a treatment history. We really agreed that that should be somehow included in the definition. Also, somehow we plan to include the active persisting disease. And finally, we agreed that at least moderate disease activity can be a part of it, signs or symptoms suggestive of active disease as an alternatively, or inability to taper glucocorticoid treatment, or in case of rapid radiographic progression, or in case of rheumatoid arthritis symptoms, which lead to the reduction of quality of life. So any of these five, as we initially thought, might be the part of the definition as a sub-item of the second part. And as a third part, we also planned to include management of signs or symptoms as problematic according to the idea of either the rheumatologist or the patient. So I would like a little bit to discuss in more details the definition of difficult to treat rheumatoid arthritis, but it has different components. Why is a disease difficult to treat? For example, due to comorbidities, which is a major reason of difficulty in treatment, behavioral or lifestyle factors, failure to glucocorticoid or DMARD therapy, and rapid radiographic progression are important elements of the difficult to treat disease. What is the problem with comorbidities? And there are several problems. One is, for example, that comorbidities may limit treatment options or fuel inflammation. For example, infections, malignancies, these are inflammatory conditions and will increase the inflammation, and chronic diseases, chronic heart failure, liver dysfunction, osteoporosis also may limit treatment options. And this comes back to the previous question. So in case of chronic kidney disease, for example, or methotrexate intolerance, we have less choices to pick the appropriate medication. And there are also non-inflammatory conditions which are important and may represent a diagnostic problem, or may represent an important comorbidity such as fibromyalgia or depression, which require a different treatment approach. Lifestyle factors are also important, and this also refers to one of the previous questions. Medication non-adherence, non-persistence are frequent reasons probably of difficult to treat disease. Socioeconomic factors, overweight, again from Professor Van Laar's case, poor coping strategies, and several other behavioral factors might be very important. Another subgroup of difficult to treat diseases, the refractory disease. If the patient has rheumatoid arthritis, which is refractory to conventional synthetic, targeted synthetic, and or biological DMARDs, which may overlap with the rapid radiographic progression or may not fully overlap, because in some cases the patient has a low disease activity close to remission and still has radiographic progression, which is by itself is a problem, obviously. Or these may exist together. Any of these four major factors may exist together, and that may further make it more difficult to find the most appropriate way to treat the disease. So when we started this work a couple of years ago, we thought that it might be important to collect opinion from colleagues who are working with patients with rheumatoid arthritis. And we realized that this will be a very heterogeneous patient population, and the definition of this patient population will not be very easy. So to collect ideas, to collect input from colleagues, we prepared an international survey, and this survey was published in the Annals of Rheumatic Diseases 3 years ago. And basically, just to show that we received many responses from the Czech Republic, Hungary, Germany, UK, Italy, France, Portugal, the Netherlands, or from Romania. Altogether, we received 410 respondents from 33 countries. And one crucial part of the survey was how to define difficult to treat rheumatoid arthritis based on disease activity. And so here the doctors had different options, and the most selected version was DES28 is higher than 3.2, or if not higher, if it's lower, then the presence of signs suggestive of active inflammatory disease activity might be enough to support difficult to treat disease. It was less selected to have a similar definition, but with a cutoff 5.1. Another important part of the survey was to ask opinion of colleagues regarding treatment with glucocorticoids. And here the most selected option was that unable to taper glucocorticoids below 10 milligram per day, and then less selected, but still like 43% of the colleagues favored unable to taper below 5 milligram per day prednisolone or equivalent. We also asked regarding treatment failure history. As I mentioned initially, that was also a major part of the survey. And here the most selected version was that 48% of the respondents selected at least 2 conventional synthetic DMARDs and at least 2 biological or targeted synthetic DMARDs. And 26% of the respondents selected the at least 2 conventional DMARDs and at least 3 biological or targeted synthetic DMARDs with different mode of action. And it's also important question if we should include fatigue or not. And we discussed that several times, and we asked also in the survey. And here, interestingly, although this is one of the most important complaints of the patients clearly, but still 58% of the respondents said that we should not include fatigue in the definition, because our idea was that it would not like clearly distinguish different patient groups. It's so common. And finally, we decided not to include fatigue, and the task force agreed with this answer from the survey. So based on the survey and based on the idea and the opinion of the task force members, finally we established the EULAR definition of difficult to treat rheumatoid arthritis, which has 3 major parts. The first part refers to the treatment failure history. So treatment according to the current EULAR recommendations and failure of at least 2 biological or targeted synthetic DMARDs after failing conventional synthetics. In case these are not contraindicated. If these are contraindicated, then the treatment part, the first part, can be met with less either synthetic or targeted treatments. The second part has 5 sub-elements, as I already mentioned, and any of these, one at least, is enough to meet the definition of difficult to treat array. So the first is at least moderate disease activity according to validated composite measures, including joint counts, or the second one, signs and or symptoms suggestive of active disease. The third is inability to taper glucocorticoid treatment less than 7.5 milligram per day. And this is also completely in accordance with the survey. The fourth is the rapid radiographic progression, also mentioned that it's important. And the last one is from this second part, well-controlled disease, but still have airway symptoms which lead to the reduction of quality of life. And this really refers to non-inflammatory problems, for example. So that should be the second one, and at least one is required for to fulfill the definition. And the third is a really subjective criteria, but the task force felt that it's important that the management of signs and or symptoms perceived as problematic by the rheumatologist and or the patient. So this is the definition which was published in the Annals of Rheumatic Diseases half a year ago. And I would like to mention the name of staff colleagues and many thanks to everyone who contributed to this work, especially the steering committee, Nadia Roderis, Melinda Kedves, Attila Hamar, Paco Velszín, Desiree van der Heijden, and Jaap van Laar, and all task force members, including Elena Nikiforiou and all others. So thank you so much for your support. And also many thanks to EULAR, obviously, for supporting this work. And basically, the guidance is on the way. And I hope that next time we can discuss that as well. We plan to publish the guidance later this year. Thank you so much for your attention.
All right. Thank you very much, Georgia, for a nice presentation. So just to remind the audience that you can submit your questions via the Q&A button. Maybe I can kick off. So how does this kind of shared expertise and consensus, how can that be translated into clinical practice? How would we change the management of patients?
So I think that's the real question, what you just asked. And this was the original approach. Then if we start treating the patients according to the EULAR recommendation, which is really very useful, sometimes we are in a position that we already tried several medications and there's no further guidance what to do. So our idea was not to go without further consideration to the next and the next and the next treatment and increase immunosuppression, but to step back and think about the possible solutions. So a first thing to think over, is this difficult to treat or not? And now we can answer that question. I think this is important. And this was already published. And if it's difficult to treat, we will provide a clinical guidance what to do step by step. That's the aim. And I think and I hope that this will work in a clinical practice, and this will lead to more manageable conditions, much more non-pharmacological options, and more optimized pharmacological treatment options as well. So I think that it's a different approach to treat patients with RA at a certain point. Everything would be the same until you have problems. So you can start treatment early and aggressively as suggested, and then go step by step. And if you are in phase 3, according to the EULAR recommendations, and it's difficult to treat, then that's another approach, and that's what we are working on together.
Right. And I think, an important point is the role of, imaging and ultrasound, right, to confirm the presence of synovitis.
Absolutely, very important. And here I would like to refer to, I think, a major challenge to us, I guess, because the challenge is that we would like to have the diagnosis as soon as possible and treat the patients effectively. This inevitably, I think, may lead to uncertain diagnosis and may lead to overtreatment in some cases. So that's why in parallel with this, and we also know that imaging is not part of the classification criteria, I think that in parallel with this, it's also important to have these milestones, as we are planning this as a milestone together, like to step back and to reconsider what to do. And that particular part, what we are working on, will include some imaging suggestions as well. I think we may say this already. Yes, imaging is very important in the management of difficult to treat, and imaging will have to clarify what's going on. If there is inflammation, what is the extent? If the erosions are characteristic for rheumatoid arthritis, so radiographic progression questions, inflammatory nature of the disease, and so on, synovitis activity. So all these, I think, from all these point of views, imaging might be very useful.
Yeah. Okay, so there are 2 questions in the chat box, but I suggest that we keep them for the panel discussion at the end. Also, Elena, 1 question, osteoarthritis as a comorbidity. You may touch on that. And then the second question on treatment recommendations, we can come back to that question. So I think we need to move on for the sake of time. Elena, I think the floor is yours for the final presentation of today.
Thank you, Jaap. Yes, indeed. So comorbidities in difficult to treat are an important topic. Can you hear me now?
Yes, now it's okay, Elena.
Okay, brilliant. So comorbidities in difficult to treat RA, we've already touched on this a little bit. We've heard a little bit from Jaap and Georgi about this. So clearly a very important topic in the context of RA generally, but more specifically in difficult to treat disease as well. Next. So what I aim to cover in the next 10 minutes or so is to briefly take you through some of the terminology. Then we will focus on the role of comorbidities, the burden and challenges they pose more generally in RA, where most of the evidence is, and where the evidence exists more specifically in difficult to treat disease. I will finish off with some reflections on clinical care, focusing on the broader view. Next. So I have a few take-home messages integrated throughout that I wish to relate to you. Starting from the definition, the first message to give is that the use of the term comorbidities has been rather inconsistent in the literature. But in the context of difficult to treat RA, a more encompassing term such as multimorbidity is likely more relevant. And you will see what I mean by this as we go along. Next. So when the term comorbidity was first coined by Alvan Feinstein in the 1970s, it was described as the presence of a distinct additional clinical entity, additional to the main or index disease. With time, we have come to understand that these conditions are not necessarily completely distinct from the index disease. And in fact, many share common mechanistic pathways, with inflammation being the culprit. However, the term comorbidities is sometimes used rather interchangeably with extra-articular or extramuscular skeletal manifestations and complications of RA. And what is important to realize is that irrespective of which category these conditions may fall in, they can challenge the management of disease, and it is important to recognize if they exist and to target them. Next, please. So the second message to share, which I think is now pretty well known, is that comorbidities add to the burden of disease. Next. So they can challenge its treatment, contribute to polypharmacy, they can affect outcomes and influence prognosis. On top of these, there are added layers of complexity that may be present. Next. For example, you can see that increasing age, which naturally associates also with increasing comorbidity burden and frailty, can add another layer of complexity. And if you next, yeah, thank you. And if there are adverse social factors, for example, unemployment, low education, poverty, all of these contribute to the challenge and all potentially contribute to what we refer to as difficult to treat RA. Next, please. So there is ample evidence now that comorbidities are highly prevalent in RA, even on first presentation of disease. So it is important to be vigilant of them in routine clinical practice. And that's, again, an important message I'd like to give. Next, please. This is work from our group based on two of the largest and longest rheumatoid arthritis cohorts in the UK, the ERAS and ERAN cohorts. And this study demonstrated that comorbidity is an important issue, even on first disease presentation, with the burden of comorbidity, as you can see from the curves shown on these graphs, increasing over time, probably partly also due to better screening and diagnosis of comorbid disease. So us getting better at recognizing and diagnosing it, essentially. Next, please. So in a separate study based on the ERAS cohort, we have shown that there is an increase over the 15 years of follow-up in our patients in that cohort in the total number of comorbidities, the top line you can see there, the Charson Comorbidity Index, so a generic comorbidity index, that's the middle line on the graph, and specifically in RA, there was an increase in cardiovascular comorbidity, which is the bottom line you can see on that graph. Next. In line with our findings, a US-based study showed that multimorbidity is highly prevalent in RA and progresses more rapidly in patients with RA, this is the blue line on these graphs that you can see here, than in patients without RA, which is the gray line on the graphs, during and immediately following RA onset. The different panels you can see here show different analytical approaches in this study. The first one assessing 44 chronic conditions. The middle one excludes conditions known to be associated with RA or that could be misclassified as RA. And the last one is the original 44 conditions, but in individuals with at least 3 years of data prior to the index date. So In other words, the date fulfilling an RA algorithm that the investigators used. Next, please. So comorbidities are important to recognize and manage. But what has become apparent over time, and it's reflected in this message I share with you here, is that guidance and appropriate management of comorbidities in RA represent an unmet need. Next, please. Now, Georgi has already presented the findings of this international survey, and just to reinforce an important finding, there was wide variation in concepts of difficult to treat RA amongst healthcare professionals, as you've heard, and importantly, there was recognition that comorbidities are missing from current management recommendations. And I'm sure there will be some discussion around this at the end. Next, please. Despite the lack of general recommendations, though, it is important to place emphasis on comorbidities in RA, as we know from the accumulating evidence in the literature that they negatively impact on disease outcomes and they contribute to difficult to treat disease. Next, please. Insights from the EULAR Task Force Group on difficult to treat RA, as we've also heard earlier, suggest that factors contributed to difficult to treat disease can be categorized into two classes: those that increase the drug ineffectiveness and adverse drug reactions, and this can result in drug discontinuation. And again, this is relevance to the question we had earlier on methotrexate intolerance and the potential impact that could have in difficult to treat RA. And secondly, factors such as comorbidities and negative disease outcomes like joint damage, for example, which can hamper proper grading of RA activity. So these factors might result in inappropriate treatment decisions and consequently treatment failure and problematic management of the patient as a whole. Next, please. High BMI and obesity are amongst the most commonly discussed in the literature in the context of difficult to treat disease. And studies have shown, and you can see some of them here, that obese RA patients generally have worse subjective measures of disease activity and increased pain and comorbidity compared with non-obese RA patients. They also have a decreased likelihood of achieving remission during the early phase of their disease. A recent meta-analysis showed that obese RA patients have less chances of achieving disease remission and that the probability of maintaining sustained remission was significantly reduced. Another study, was a Scandinavian study, showed worse long-term outcomes, including a higher prevalence of comorbidities for RA patients with obesity. And there is also the evidence of bariatric surgery, which has been associated with reduction in disease activity. Next, please. So what the data tell us specifically for RA is that obesity is linked to worse disease activity, more pain, and other factors which naturally complicate the management of disease, contributing to difficult to treat RA as recently defined. And in this study you see here, using UK Inception cohort data, we have shown that RA patients with higher BMI, so the obese compared to overweight or normal BMI individuals, had worse disease activity, an effect that was independent of the swollen or tender joint counts. And in this analysis, this observation was notable at 2 years in particular. Next, please. This study here aimed to evaluate the joint-specific association between synovitis measured by power Doppler ultrasound and the clinically swollen joint in overweight and obese RA patients. And the bars represent the different levels of BMI. On the left-hand side, you see swollen joints, and on the right-hand side, the non-swollen joints against the proportion of power Doppler ultrasound positivity. In an obese RA patient, the gray bars here, a clinically assessed swollen joint was less likely to represent true synovitis as measured by power Doppler. In addition, clinically swollen joints had higher rates of power Doppler positivity compared to non-swollen joints, and there was a decreasing trend, as you can see, on power Doppler positivity with increasing BMI for both swollen and non-swollen joints. So the implications we're seeing here are more in terms of the accuracy of disease evaluation, which can subsequently impact on treatment decisions and outcomes. Next, please. And we know that obesity associates with other conditions, such as fibromyalgia. Again, we've heard a little bit about this previously. And the coexistence of fibromyalgia and obesity has been linked to more disability, more depressive symptoms, and a higher level of polypharmacy. It is therefore not surprising that these two conditions often come up in the context of difficult to treat RA. And this study showed that a lot more patients with fibromyalgic RA had a DAS of higher than 5.1, and the odds of having active disease by DAS criteria with fibromyalgic RA, which are the gray bars here, compared with RA without fibromyalgia, the dark blue bars, were much higher. And the same situation occurred if the DAS28 was replaced by CDAI, which are the middle bars here, with fibromyalgic RA patients again having an increased likelihood of being classified as active. In contrast, using more conventional assessments based on reaching predefined numbers of tender and swollen joints and a high ESR showed that only a minority of patients with fibromyalgic RA had active disease. And these are the three bar charts at the end. And I think one should keep in mind that there's several factors that might confound clinical interpretation of disease activity. And this includes psychological distress, for example, somatization complaints, or even when there is long-standing disease with associated damage. This can also complicate matters. Next, please. Evidence has also shown that comorbidities impact on the achievement of treated target goals in RA. And here we see that for every additional comorbidity, the chance of remission after 1 year was reduced by around 30%. You see the ratio there of 0.72, and that of low disease activity was reduced by around 20%. Next, please. Comorbidities also negatively impact on function in RA. And the graph here on the left-hand side shows data from the ERAS cohort in the UK, where we saw an accelerated decline in HAQ score over time with increasing comorbidity burden. And many other studies, as you can see here, have also demonstrated the impact of comorbidity on functional impairment. Next, please. Comorbidities also impact negatively, not surprisingly, on the overall quality of life, with, as shown based on cross-sectional data from a US cohort shown here, a strong, almost linear, as you can see, association between the EQ5D and comorbidity burden. Next, please. And finally, where survival has been associated with increasing comorbidity burden, as shown in this study, whereby comorbidities were found to be amongst the strongest predictors of mortality. Again, as you can see here, both in univariable and also multivariable models. Next, please. So going back to what I briefly referred to at the beginning, with needing to have a more encompassing term for comorbidities, an important message I'd like to give is that current times and current knowledge and management considerations demand that we divert away from the index of a single or index disease to a more holistic and patient-centered concept. Next. And in this schematic here, we try to convey this shift in concepts and priorities in terms of clinical management, a shift away from the emphasis being on the index disease, in this case RA, and its treatment, to a more patient-centered approach. You can press the button again, with the emphasis on the patient and the RA and any other patient or disease-related factors such as comorbidities, all given adequate early attention and managed properly, whilst acknowledging potential interactions and impact on disease outcomes and the patient as a whole. Next, please. So I will stop here, and if I was to sum it all up and leave you with one main message to take away, then this will be that comorbidities should be identified and targeted early in RA generally, and more so in those patients entering the grounds of difficult to treat RA. Thank you.
Thank you, Elena, for a really nice and important presentation. Maybe you can take on this question of osteoarthritis. You know, how does this interfere with the burden of disease in rheumatoid arthritis as a comorbidity?
I think potentially in at least 2 or 3 ways. Firstly, complicate the actual, I referred earlier to the accuracy of the diagnosis, so it could have an impact there. Patients will have joint involvement, inflammatory symptoms, maybe they can have pain, the pain element, which can complicate the diagnosis, an accurate diagnosis of difficult to treat disease. Secondly, the treatment, the management of the patient. Having dual joint pathology essentially, and having to manage both of those. And thirdly, the treatment element, polypharmacy, additional pain relieving medications. So I think of at least 2 or 3 different ways this could impact.
Yeah, no, I fully agree. And I think it's, although I've been a rheumatologist for over 25 years, I still find it difficult sometimes to diagnose patients who have or to differentiate inflammatory osteoarthritis from rheumatoid factor negative rheumatoid arthritis. So kind of
absolutely. And some of these patients may end up on hydroxychloroquine. I know some people use this, and then it just complicates matters more and more.
Yeah. Georgi, here's a question for you. So, we have this paper submitted on the EULAR recommendations now, and can you disclose anything about specific information on treatment recommendations?
Yeah, I just would like to agree first with you guys that it's very difficult sometimes to clarify if it's inflammatory or not, osteoarthritis or RA. And I would also like to add that sometimes both are present, and that's not an easy situation. So we should deal with it. Yeah, basically, we have here, I think we have 2 questions here from Takahiro Suzuki and Ricardo Xavier. We can, I think, discuss the 2 together. So basically, one question refers if we are thinking about creating recommendations, and another one is regarding how can we cover with one definition this broad range, different types of patients without inflammation and wide variety of management strategies. So basically, yes, the main purpose of the whole work is to create a management guidance, and this is what the task force did. This is just the definition itself as an important part of our work. The major part is coming soon, and we really hope that it will be available to everyone in the near future. So it's under consideration currently. And again, I would like to emphasize that we are trying to create something which is very practical, very simple, and can be used in the everyday clinical practice to make sure that we do not run from one medication to another without careful consideration. It's a new approach with a lot of non-pharmacological considerations and some very delicate pharmacological add-on considerations. And basically, you're very right if you say that it's a little strange that we are trying to cover this very heterogeneous patient population with one term. On the other hand, from clinical point of view, we believe that it's useful because this definition is true for all patients, and we are trying to create the algorithm which is step by step. And if you are sure that you do not miss any of the steps, that hopefully will help a lot in the management. So that's the plan. We are trying.
Elena, back to you. Regarding comorbidities, how do you assess comorbidities quantitatively in the outpatient clinic? Do you use the Charlson Comorbidity Index, or what's your normal way to tackle that?
Thank you for that question. Yeah, I mean, no, I do not use the Charlson because it's a very generic index. It was developed in acute general medical wards as a predictor of mortality more than the functional disability and other elements that we look for in our patients. But I use basically very much common sense. There's a list of 30, 40 comorbidities that I actually, they're fixated in my mind. I start with the commonest ones, cardiovascular, respiratory, and I work my way down. When I was briefly in Finland, I experienced there the outpatient clinic system they had, where they had an online system with 33 listed comorbidities, and basically we would screen through them and select. It's a similar kind of thing. I mean, the one thing I would say about these indices is that they're not very encompassing. You know, they include some, not all, and it's important to have a very open mind when we assess our patients.
Mm-hmm. Yeah. Yeah, I'm afraid we're coming to the end of the webinar. Georgi, there's one other question on the Q&A which you might be able to tackle. I think we need to.
Yeah, I don't see the question.
Oh, sorry. So why didn't we take into account the ACPA titer when defining difficult to treat RA?
This is, I think, this is also a good question. Initially, we could create subgroups of patients with drug-resistant disease, with non-inflammatory, with comorbidities. That would be one approach, how to deal with this problem. We decided a different approach. And for example, defining patients with a lot of bad prognostic factors, such as high ACPA titer, rheumatoid factor, genetics, and so on, would be that way. So that would be another way. We preferred another one, which I think in the clinical practice will work better, and that's an umbrella term. And then we will open this up in the future, and we will define that particular patient population which is problematic because of bad prognostic factors, including high ACPA titer and so on, and we will provide management options for this particular patient group. I think that's just another approach, but it will be covered in this way. So I cannot tell you the details regarding the guidance, but I would like to, but it's not open for discussion yet. In the near future will be.
Okay.
I hope it answers in a part of the question.
Yeah. Okay. So just to come back to the question that we started our webinar with, this patient was put on subcutaneous methotrexate. She was afraid of methotrexate, so we started with a low dose and slowly increased the dose. We advised her to not change the prednisolone dose all the time, and we advised her to lose weight and work less. And with all these measures, we managed to get disease activity in this lady down to satisfactory levels. So I hope that you found this webinar interesting on difficult to treat rheumatoid arthritis, a new concept with a new definition, and I think that it also should stimulate you to use this in clinical practice with your patients. Next Wednesday, sorry, not next Wednesday, on Wednesday, 7th of July, Professor Chris Edwards will present the next webinar on the new therapies for patients with immune-mediated inflammatory diseases with JAK inhibitors. And I also recommend and ask you to fill out the feedback form so we can learn from this. And for those of you who are still asking questions through the Q&A box, we'll stay online for a few more minutes and answer the questions. So thank you very much to Georgi and Elena, and of course the organization, and I wish you well. Thank you. Bye-bye.
Thank you.
Thank you all, and thank you, Jaap, for sharing.
Likewise. Bye, everyone.
Okay.
Thank you. Also, thanks to the company for organizing and for the very good technical background. I don't know if we have more questions. I don't see.
I think all the questions are done now. So just on our behalf leaves us to thank you, and we'll send you the notes and the evaluations. Thanks, you've been great to work with, and we'll hopefully do it again sometime soon.
That will be great. We look forward.
Okay, take care.